In this video, we're going to talk about dialysis and dialysis modalities and hopefully demystify what dialysis is exactly. So dialysis is actually a term from chemistry, and it really just refers to diffusion of particles across a semi-permeable membrane. So here we have a semi-permeable membrane in the middle, and we have particles on both sides, and let's assume we have solutions holding these particles, and as you can see there's more on the left side than on the right side. There's 14 particles here, and there's 3 particles here. Now, remember, all the particles are just moving randomly in what we call Brownian motion, and so all these particles are moving in random directions, and just because there's more particles on the left side, more particles will move from the left to the right, and this will eventually result in diffusion of these particles across that membrane. So now if enough time has been allowed to pass, we'll have equal numbers of particles on both sides of that membrane. So this is essentially what dialysis is. On one side we have the patient's plasma, and remember the plasma will include uremic solutes, high levels of potassium, low levels of bicarbonate. Then we have our semi-permeable membrane, which will allow only passage of small solutes and molecules. And then we have the dialysate, and so this is a solution that contains higher levels of bicarbonate, physiologic levels of calcium, and maybe low levels of potassium. And so as long as there's a difference in concentration between the solutions on both sides, solutions will move via diffusion, right? And so that term is dialysis. So what moves back and forth across the membrane is highly dependent on the pore size. And so a typical pore size for a dialysis membrane is maybe 10 to 100 angstroms wide in diameter. So this permits small molecules, ions, and maybe very small proteins. Typical sizes would be anything less than about 5,000 Daltons in molecular weight would be able to pass through these pores. And different dialysis membranes can have varying degrees of pore size, so keep that in mind. But in general, it's worth noting what's on both sides of the membrane. So on the patient's side, there's a lot of solute. So these small molecules and ions, so potassium, uremic solutes, those would be able to pass through the pores, okay? What about large immune globulins? So these would not be able to pass through because they're too large. What about albumin here? So albumin would not pass through. So large plasma proteins would not pass across a typical dialysis membrane. Small solutes, drugs, very small proteins, and ions would pass through. And the same thing goes for the dialysate side. It contains high levels of bicarbonate, and so the typical patient who needs dialysis would have lower levels of serum bicarbonate due to metabolic acidosis. So in this case, serum bicarbonate would increase because we're providing it from the dialysate. So keep in mind the pore size and what can pass across it and what can't. And remember how solutes will only move if there's a concentration difference? Well, because of that, we take advantage of that fact and we run the dialysate and the plasma in a counter-current fashion. That way we're always maximizing the concentration difference between solutes on both sides. So now we're going to talk about dialysis modalities, and first is one that you may be familiar with called hemodialysis. And this is one in which the patient's blood and plasma is actually removed from the body and placed into a dialyzer where it is cleaned. So this represents a dialyzer, and so the patient's blood comes in through the top, and inside the dialyzer is a series of many tiny tubes. And so these tubes are very small, and the lining of the tubes have those pores, so the same pores we saw just before this image, right? And so these tubes are bathed in the dialysate, and so the dialysate is pumped in here, and it moves in a counter current direction than the blood flow. Okay, so blood's moving inside the little tubes. The tubes are surrounded by dialysate, and the tubes are the semi-permeable membrane with the pores. Okay, and then cleaned blood is removed and is returned to the patient. There's another form of dialysis called peritoneal dialysis, and so this form of dialysis uses a peritoneal dialysis catheter, which is implanted into the patient through the abdomen, and it sits inside the peritoneal cavity. In this form, dialysate is actually pumped into the abdomen where it sits and actually dwells over a period of time. And so if we could zoom in on the peritoneal membrane, we would see something like this right here. There's peritoneal capillaries lining the peritoneal membrane, and these are peritoneal epithelial cells. And so solutes here would diffuse in this direction, right? And so the solutes will diffuse into the peritoneal cavity where the dialysate is at, and then that fluid, which is now equilibrated, can be drained, and then new fluid can be pumped in, which does not contain any solutes, and the same process can occur again and again, sort of like a rinse and repeat procedure. So this is sort of a little animation that's going to show how peritoneal dialysis works. And so here you have the dialysate, and so it is slowly pumped into the peritoneal cavity where it fills and surrounds the bowels and lines the peritoneal cavity. And so this will dwell for a period of time. And so as it dwells, solutes will move from the patient's plasma into the dialysate. Okay, and so over a period of time, this will sort of maximize. And then after the time is done, it will drain out. Okay, and then essentially what we did, we put in clean fluid and we got out fluid that contains solutes, potassium, and uremic toxins. Okay, and then we'll just fill it back up. And so we'll do this a number of times, and this could happen 4 or 5 times a night. And as you can imagine, if you do this enough number of times, it performs dialysis and cleans the patient's blood and essentially replaces kidney function. So now it's time to talk about ultrafiltration or fluid removal. Everything we talked about before was about diffusive clearance of solute, so removing things like potassium, uremic toxins, and the like. Now we're talking about removing actual fluid because, as you may know, patients with kidney failure can't excrete water and salt, so they can become hypervolemic or volume overloaded, right? They can have pulmonary edema, lower extremity edema, and so we have to have some way of regulating fluid balance, and we have to do this through dialysis for patients with end-stage kidney disease. With hemodialysis, it's relatively straightforward in that we can use hydrostatic pressure. Literally, the machine can set up a pressure gradient so that we're pulling fluid across that membrane. And so the dialysate can not only perform diffusive clearance of solute, but using hydrostatic pressure, we can remove fluid from the patient. And so it's not uncommon for a patient on hemodialysis in a single treatment to have maybe 2 or 3, sometimes even 4 liters of fluid removed in a single session. In peritoneal dialysis, it's different. Here we use osmotic pressure to pull fluid across the peritoneal membrane to achieve ultrafiltration. And so we do this by infusing dialysate that has an osmotically active substance in it. And so dextrose is osmotically active and it's relatively inexpensive, so a lot of PD solutions tend to use just dextrose. And so you can see here there's 3 different patients with 3 different concentrations of dextrose. And so this solution has very little dextrose, this one has sort of a medium amount of dextrose, and this one seems to have a lot of dextrose. So as you can see, the strength of the concentration of that osmotically active substance will determine how much fluid is moved from the plasma compartment into the peritoneal fluid. And then when the dialysate is drained out, you've achieved net fluid removal. So now I want to spend a little bit of time on continuous renal replacement therapy, or CRRT for short. And so as implied in the name, this is continuous, and so it's 24 hours a day, typically, form of renal replacement therapy, and we only do it in the ICU as it's only used for critically ill patients who maybe do not have good enough blood pressure or cardiac function to tolerate intermittent hemodialysis. Okay, so just to recap, hemodialysis refers to diffusive clearance of solutes and toxins, and so typically most CRRT machines have the ability to do hemodialysis, which is where we're just putting the patient's plasma with all the solutes on one side. They move across the semi-permeable membrane to the dialysate on the other side. And so most CRRT machines are able to do hemodialysis. In addition, some CRRT machines are also able to do something called hemofiltration, which is clearance of solutes by convection. Now this can be a little confusing, so I'm going to explain this. Essentially, convective clearance means we're going to physically remove fluid by hydrostatic pressure. All right, so across this membrane, we're going to apply pressure. We're going to remove fluid that contains all the solutes. And so you can see on the other side here, we've collected plasma fluid that contains high levels of potassium, urea, and other uremic toxins, okay? But at the same time, distal to where we took off this fluid, we're going to give what we call replacement fluid, which is a physiologic type of fluid, essentially what we want the patient's plasma to look like. And so this will have normal concentrations of bicarbonate, it'll have normal concentrations of potassium and other things. And so at the same moment as we remove fluid that contains solutes, more distally, we give replacement fluid back to the patient, and this is all at a 1-to-1 ratio, so there's no net movement of fluid at this part for hemofiltration. And then, of course, on top of all this, the CRRT machine can also remove fluid by ultrafiltration through hydrostatic pressure differences. So some CRRT machines can do both hemodialysis and hemofiltration at the same time. Some of them make you choose one or the other option, but either way, these are useful tools for solute removal and keeping the patient in good balance. And then also ultrafiltration is necessary to remove fluid. And so this is the preferred modality for critically ill ICU patients who are hypotensive or have sepsis or shock or cardiac dysfunction that would make intermittent hemodialysis unsafe.